So in the previous lecture, we talked about two subjective tests that are routinely used as a part of an audiological evaluation, pure tone audiometry and speech audiometry. Um, in this lecture, we're going to talk about two more objective tests. We talked about tympanometry and acoustic reflexes, which are examples of an objective test. In this lecture, we'll talk about otoacoustic emissions and auditory brainstem response uh, testing, which are also done with minimum participation from the patient. And they're also known as physiological tests because they give us information about some physiological aspects of the auditory system. Both of these tests are routinely used in newborn hearing screening. One or the other is commonly used. Typically, in Tennessee, hospitals use the auditory brainstem response testing as a part of the newborn hearing screening protocol, and that's often done within a day or two after the baby is born, and likely they'll complete it before the baby is even discharged from the hospital. We briefly talked about otoacoustic emission when we talked about cochlear physiology, how the evidence, otoacoustic emissions are the evidence that supported the claim that something active is going within the cochlea. The first researcher who recorded otoacoustic emission is David Kemp. He was a British researcher who actually recorded these echoes using a sensitive microphone placed in the ear canal. And the type of otoacoustic emissions that he recorded are known as spontaneous otoacoustic emissions. So these are acoustical sounds that are actually emitted from the cochlea, from a healthy cochlea, even without any external stimulus. And these are the byproducts of that active system, which is primarily now we know is by the outer hair cells. So recording these otoacoustic emissions not only, well, it's an objective test, primarily giving us information about the function and the integrity of the outer hair cells. And we also briefly mentioned in the previous lectures that the outer hair cells are very sensitive to damage, and usually they're the first to be affected by conditions like ototoxicity, some of those drugs that might result in hearing loss, and in cases of noise-induced hearing loss, the hearing loss resulting because of exposure to loud sounds. In these cases, the outer hair cells are kind of the first defense and are affected by these conditions. Now, since otoacoustic emissions is a reflection of the outer hair cell activity, it provides us a valuable objective tool to assess these important structures within the cochlea. And essentially, to record otoacoustic emissions, all we need is a sensitive microphone, and we try to get it as close as possible to the tympanic membrane. And the probe that we use for otoacoustic emissions, and the otoacoustic emission testing, is quite similar to what's used for tympanometry. But unlike tympanometry, we would not need an airtight seal to record otoacoustic emission, but we need a snug fit, and the probe is kept as close as possible to the tympanic membrane. The otoacoustic emission travels in the opposite direction as to sounds that actually travel through our auditory system. So in other words, they are emitted by the outer hair cells, so they travel from the cochlea through the middle ear, and they vibrate the tympanic membrane from the opposite side, resulting in these echoes that can be recorded with a sensitive microphone. So these otoacoustic emissions are a reflection of those active processes within the cochlea, and they're a result of that electromotility, that dancing outer hair cells. So in this schematic illustration, you see when there's an acoustical stimulus, uh, eventually that results in the basilar membrane vibration. When that happens, it results in the deflection of the stereocilia of the outer hair cells, and that changes the current within the outer hair cells, making it move. So in other words, the outer hair cells elongate and shrink, and pumping in more energy into the basilar membrane vibration. So now the basilar membrane vibration becomes amplified, and it's that amplified basilar membrane vibration that stimulates the inner hair cells that eventually take the information to the auditory nerve. So in this figure, you're seeing a graph of the basilar membrane's traveling wave. If it was a passive system, this traveling wave would have a shallow peak. But when the outer hair cells do its job, it results in amplifying this wave, amplifying this displacement, and also it sharpens the peak of this traveling wave. So not only the sounds become louder, I mean the displacement becomes louder, also it results more sharper, improving our pitch discrimination, our frequency discrimination. So if you were to record the spontaneous otoacoustic emissions, it would look like this. So they spread predominantly in the lower frequencies, and it looks like a noise which is dominant in the lower frequencies. And these are very soft sounds, so hence the need for a very sensitive microphone that just captures this energy and filters it out from the background noise. So the presence of the spontaneous otoacoustic emissions is a good proof of a healthy outer hair cells system. However, it's spontaneous otoacoustic emissions by itself is not considered a reliable clinical tool, because there is, for some reason, 50% and 50% of even normal hearing individuals who don't have significant spontaneous otoacoustic emissions. But there are other otoacoustic emission measures that are used, which are more consistent and reliable. And those are the ones that are typically used in the clinical protocol. So spontaneous otoacoustic emissions are typically seen in the frequency range of 1,000 to 3,000 hertz. And as I said, they are very soft sounds, so at the most they're about 10 dB SPL in intensity. So the other class of otoacoustic emissions that are routinely used in clinics falls within the class known as evoked otoacoustic emissions. So here we present some stimulus to evoke these echoes. And depending upon what stimulus we use, we have two types of otoacoustic emissions that are commonly used. One's the transient evoked otoacoustic emission. The other one's a distortion product otoacoustic emission. And the difference between these two is primarily the stimulus that you use to evoke these otoacoustic emissions. Otoacoustic emissions are widely used and, as I said, as a valuable clinical tool because they provide objective and a quick estimate of an important structures within the cochlea, namely the outer hair cells. And as hearing loss if there's a hearing loss because of a conductive problem or a cochlear problem, the amplitude of this evoked otoacoustic emissions decreases as a degree of the hearing loss increases. And if the degree of the hearing loss is beyond 40 dB, in other words, if it's beyond a mild hearing loss, you will not be able to record otoacoustic emissions. So Hence, it can be used as a good screening tool for um, especially in populations that are difficult to test or would not be able to provide reliable behavioral responses. Um, it's important to note that when you record otoacoustic emissions, and if you see a normal appearing otoacoustic emission, um, you can only infer that the auditory system is intact up to the cochlea. Um, that's important to note because the otoacoustic emissions do not provide information beyond the cochlea. The origin of the otoacoustic emissions is within the cochlea. So if there is even an extensive damage beyond the cochlea that precludes normal hearing, such as like a tumor growing in the auditory nerve or multiple sclerosis affecting the the eighth cranial nerve, you might still record normal appearing otoacoustic emissions. But on the other hand, otoacoustic emissions can be used for differential diagnosis between a neural and a cochlear hearing loss. In one of the discussions, in the discussion board, somebody had inquired, well, if we do diagnose a sincere neural hearing loss, how do we differentiate between whether the problem is in the cochlea or in the auditory nerve? Now, this otoacoustic emission can be used as a test to differentiate that. So in case if you see a sincere neural hearing loss, and but you are able to record normal appearing otoacoustic emissions, then the inference would be that the problem is beyond the cochlea and quite possibly in the auditory nerve. And that's critical information because potentially a neural problem can be life-threatening because the auditory nerve traverses through the brainstem and it goes in close proximity to a number of neural structures in the brainstem that are important for life-sustaining tasks such as breathing and maintaining the blood pressure. So a tumor or any abnormality in the auditory nerve is important to diagnose early and being treated as early as possible. So otoacoustic emissions, since it's a quick test, it's a good screening tool. It's objective, it doesn't require the participation, so it's a good tool to be used with infants and with children. And unlike the auditory brainstem response, which requires the placement of electrodes on the scalp, the otoacoustic emissions pretty much requires the placement of a probe in the ear, like in this example over here, and it's a quick test to perform if you have a relatively quiet, cooperative child. Otoacoustic emissions also help us differentiate organic or real hearing losses from functional or non-organic hearing losses that are because of some underlying psychological reason or some intentionally depicted hearing losses, like those hearing losses that you might see with insurance claims or for some kind of benefits. As I said, otoacoustic emissions are a reflection of outer hair cells, and since outer hair cells are the first affected with ototoxicity because of some classes of medication and because of noise exposure, otoacoustic emission screening provides a very good tool to monitor the early signs of these conditions. Okay, moving on to auditory evoked potentials, within which falls auditory brainstem response. So when we talked about the cochlear physiology, we talked about how the main function of pretty much the peripheral auditory system is to act like a transducer. In other words, convert the acoustical energy into a form that the human nervous system can understand. and that kind of energy is electrical energy. Okay. So it's quite obvious that when you're hearing a sound and if the peripheral auditory system is doing its job, there is some change in electrical activity within the head. And that's what we are recording with these auditory evoked potentials. So in other words, we're recording changes in electrical potentials um, that can be recorded even by using scalp electrodes, or electrodes that are sensitive electrodes that are placed on the scalp um, and give while they're listening to some stimulus. So in auditory evoked potentials, we have these surface electrodes that kind of look like small cup electrodes that are placed strategically in different places on the scalp, typically at the minimum 3 or 4 different places. And we are monitoring the electrical activity while presenting different stimulus. The responses you get, we describe them in terms of latency. How early are you seeing the response after the stimulus presentation? What's the amplitude of the response and the overall morphology or shape of the response? So when you're presenting a brief acoustical stimulus like a click sound, like a or a tone burst, which is also a brief tonal stimulus, um, there is going to be a synchronized burst of electrical activity that's generated in the auditory nerve. So when we talked again in the cochlear physiology, we talked about the compound action potential that's generated right at the nerve ends that are connected to the inner hair cells. Um, Structures after the auditory nerve also have similar um, potentials. And again, if we have a sensitive system, we'll be able to record these changes in the electrical activity, and that's what's done with auditory evoked potentials. And these changes in electrical activity happen within a few milliseconds after the stimulus is presented. The auditory brainstem response, in fact, happens within the first 10 milliseconds after the stimulus is presented. So in other words, it happens within 1/100th of a second after the stimulus is given through the headphones or insert earphones. There are many different classes of auditory evoked potentials. The one that's commonly used and one of the earliest ones is the auditory brainstem response. And it's named so because it originates from the brainstem structures, including the auditory nerve. As I said, it happens within the first 10 milliseconds after the stimulus is given. And typically, a normal auditory brainstem response has anywhere between 5 to 7 peaks. And some of the peaks are more important for diagnostic purposes than others. And typically, they're wave 1, wave 3, and wave 5. Now, the auditory brainstem response, unlike the otoacoustic emission, is a reflection of the neural activity. So it gives us information about the auditory nerve and neural structures within the brainstem. But still, it's an objective test, and now it gives us information beyond the otoacoustic emissions. So in cases where, and that example I mentioned earlier, where if they have this tumor growing in the auditory nerve, and a commonly occurring tumor is this acoustical neuroma, this patient might demonstrate a in pureton audiometry sensory neural hearing loss, but he might have normal otoacoustic emissions. If we were to do auditory brainstem response testing, you would find out that his auditory brainstem response or ABR responses are abnormal. An auditory brainstem response, there are some protocols that are screening protocols which are quite quick and they can be done, and those are the ones that are used typically in newborn hearing screenings. So these are examples of babies being tested, and you can see in the scalp are those electrodes that are kind of placed with adhesives while sounds are being delivered through those insert earphones. Um, and one of the advantages of ABR is that the ABR response is not affected by sleep. So we would like the child to be in a calm, even if a sleepy mode. That would be preferred, since that would reduce motion artifacts while you're doing this testing. Some cases of adults also, we would do this auditory brainstem response if there are some red flags in their behavioral assessments. Some of the red flags that would kind of necessitate an ABR testing would be a sudden asymmetrical hearing loss, or if there was significant differences in the speech recognition scores between the ears. So some signs like that might require an auditory brainstem investigation to see if there's any neural pathology. So ABRs can be used to differentiate the different types of hearing loss, and it's very sensitive to those tumors that can potentially grow on the auditory nerve. They can be also used to assess post-surgical status of the auditory nerve in case if they've been diagnosed with an acoustic neuroma and they've gone for surgery and they're coming back. You might be able to compare the ABR responses before and after surgery to see functionally how the auditory nerve could be working. ABR is also used for diagnosis and monitoring other neural conditions like multiple sclerosis. As I said, it's a valuable tool for testing children and infants. And since it's an objective assessment, it's also used for medical legal cases and compensation cases if one questions the validity of their behavioral responses. ABRs are also used for intraoperative monitoring, such in cases where, for example, if they're doing a surgery like cochlear implantation, or if they're removing or doing any surgical procedure close to the auditory nerve, it would be important to monitor the status of the auditory nerve by doing this intraoperative auditory brainstem response testing. So a good normal ABR response kind of looks like that. So as I said, it has anywhere between 3 to 7 peaks. In this case, you're seeing peak 1, wave 3, and wave 5. And these are, again, very small responses. They are in the magnitude of microvolts. So compare that to 1.5 volts for a typical battery. Micro is 1/millionth of that. So you're talking about really small deflections in electricity that are captured by these equipment in response to sound. And as I said, this happens also within a very short time frame. In fact, you would see the ABR response within the first 10 milliseconds. And again, millisecond, 1 millisecond is 1,000th of a second. So it happens within quickly after the stimulus is being presented to the ear. Here is examples of auditory brainstem response for different levels of the stimulus. So if you were doing a diagnostic auditory brainstem response testing, again, your goal would be to find the threshold or the lowest level you can record an identifiable ABR response. So just like when you're doing pure tone audiometry, you would present the sounds at different levels and trying to find the lowest level where you can record this ABR response. And that would be considered the ABR threshold. And the ABR threshold is typically within 10 dB of the behavioral threshold for that stimulus. So if you have, if this child has got normal hearing, then you expect to see the ABR responses all the way down to almost like 10 or 20 dB. So the different peaks of the ABR actually originate from different structures within the auditory brainstem. Um, so the earliest peak, just to give you an example, the first peak is a response from the auditory nerve, but the other peaks, the later peaks, 2, 3, 4, and 5, actually are believed to originate from more ascending structures within the brainstem. So the brainstem refers to that, it's kind of the stalk over which the brain sits. As I said, the brainstem involves a number of important structures. And so now when you're recording this ABR response and we record a normal peaks, and kind of you can infer that many of the structures within the brainstem are within normal limits. The fifth peak is the most robust of the peak. In other words, it's usually the one with the largest amplitude. And the fifth peak is the one that's monitored down up to threshold. Okay. So they said the auditory brainstem response is not affected by consciousness or sleep cycles. So hence it's used as a valuable tool for assessing infants and other difficult to test population. If it was a younger child who normally sleep for prolonged periods of time, you might be able to do this unsedated or non-sedated ABRs. But if it was an older child, anywhere between older than 3 months, at times you might have to resort to doing a sedated ABR, where a mild anesthetic agent is given, and this procedure is done with the supervision of a medical professional. And nowadays, the sedated ABRs are typically done in ORs and operating rooms with the presence of an anesthesiologist and an ENT along with audiologist. Just to be cautious about any anesthetic related allergy. Okay. All we need is that we minimize the muscle artifact and head movement. And if you have a cooperative child, you probably can try unsedated ABR even if it's an older child before making a